Alex Earle. We're here at Pure Plastic Surgery today, and it's Hump Day with Dr. Alex Earle. So it is Wednesday. This is the time that I get to spend with you all, answering all your questions and going over plastic surgery topics from head to toe. So we are now, I guess, what's this, week 3 back from the shutdown. Everything's going awesome. Everything's going very, very well. All the new procedures are going very smoothly. Everyone's extremely happy, and we are keeping Pure a COVID-19 free zone. And that's really the most important, which is our safety and your safety as well. All right, so what is the topic for today? Today we are going to be discussing a breast lift, okay? So I've done a few of these kind of comprehensive reviews. We've done so far, we've done liposuction, we've done tummy tuck, we've done breast augmentation. We talked about last time about the body tight and the face tight and all that. So today we're going to be talking about the breast lift, okay? So breast lift has to be done when there is breast ptosis. So breast ptosis, what is that? The definition of that? Well, it means that the breast is basically it's droopy, or the breast is saggy, okay? There's different degrees of ptosis. And I kind of drew them over here, if you can kind of see my crude drawings there. But if you have a line that is the inframammary fold, so inframammary fold is that crease right there, right beneath the breast, then depending on where the nipple position is, relative to that line, that is the degree of breast ptosis or breast droopiness that you have, okay? So if pretty much the entire breast and the nipple is above that line, so typically you can get a breast augmentation and with no need for any sort of lift, okay? If your nipple position is at the level of the inframammary fold, then you have what's called a grade 1 ptosis, okay? So grade 1 ptosis is kind of the most mild form of ptosis or sagginess. And for those patients, depending on how they look, how much skin laxity they have, they either can get away with just a breast augmentation, or they may need a small lift, which we'll get into here in a little bit. All right, next, if you have the nipple position below the inframammary fold, but it's not the lowest point of the breast, then that's a grade 2 ptosis. And then finally, if you have your nipple position below the inframammary fold and it's the lowest point of the breast, basically nipples pointing straight down, then that is what's considered a grade 3 ptosis, which is the most severe form of breast droopiness or sagginess, okay? And that's important because the degree of ptosis is what's going to determine, along with all your measurements and objective measures and your desires, what type of a lift we are going to do for you, okay? So, going back to pre-op, pre-op is pretty much the same as any of the surgeries that we do here in the general anesthesia. So of course you need all your pre-op labs, you need AKG and everything that we've discussed prior. What is the only difference? Well, it does include a mammogram if you're over 40 years of age, or if you have a strong family history or a personal history of any breast issues such as breast cancer, okay? So if you have any of those issues, or you're over 40 years of age, then we will require for you to do a mammogram, okay? If you have nothing going on with the breast and you're under 40, then the mammogram is not needed, all right? Okay, so let's talk about the surgery. So what I was just talking about here is that depending on the degree of ptosis, that kind of depends what our action plan is going to be, you know, what our plan for the surgery is. So there's different types of lift that you all may have heard of. The first one is kind of, it just goes just around the areola. So just kind of circle like that, a circle around the areola. And that you can use for a very mild type of a lift, and that's typically called a donut lift, okay? There's some other more technical terms like a Benelli and things like that, but you can just think of it as a donut lift because the scar goes only circumferentially around the areola. How much of a lift can you get with that? You really don't want to lift more than say 1 to 2 centimeters or so with that type of lift. Maybe 3, but that's already starting to push it. The problem if you try to do too much with a donut lift, say you want to try to go anywhere between 3 to 6 centimeters or higher, is that it's going to put a lot of tension on that areola, and though it might look small when you're done with surgery, over time that areola is going to stretch and it's going to become very, very large, and that scar around it sometimes becomes widened or thickened or hypertrophic. So that's why you don't want to push a donut lift too hard. So 1 to 2 centimeters would probably be about the most that you could do there. All right. In the middle, we have the vertical or lollipop lift. Okay, you may have heard that term, lollipop lift. Why do we call it that? Because that one has a scar that goes around the areola and then down, then the vertical scar from the areola down towards that inframammary fold. And sometimes it kind of comes out a little bit towards the outer, towards the lateral edges there. Okay. So what is a vertical lift good for? That's typically when you want to do somewhere between 2 to probably max 6 centimeters of a lift, okay? But 6 centimeters, I gotta say, you're probably already pushing it a bit with the vertical lift there. Okay, so you get a little bit more lift, but some additional scarring with that one. Okay, and so that one you can use for your grade 1s and some of your grade 2s. All right, so the donut lift you use for your grade 1s, the vertical lift you use for some of the grade 1s and grade 2s. Depending on the look that the patient's going for. But once you start getting into like your more severe grade 2s and certainly your grade 3s, that's when you have to use that anchor type scar pattern, okay? That's kind of the classic one you see, that anchor type scar pattern where the scar goes around the areola, then you have that vertical scar that goes from the areola down to the inframammary fold, and then you have the scar that goes along the inframammary fold, creating this kind of a pattern here that looks like an anchor, and that's why we call it that, okay? So that's the one that we use for certainly anything 6 centimeters or more. Sometimes like for 5 centimeters, so you may need to use it depending on the patient, the degree of skin laxity, the look that they're going for, whether or not they're using implants, etc. Okay, so that's the decision that you got to make, the type of lift, or that we make together based on the degree of ptosis and your measurements and your desires. Okay, the other decision that you have to make is whether you want an implant or not. Okay, do all patients that get a lift require an implant? No, they don't. But what does an implant do? So the implant will provide more upper pole fullness. So if you want more fullness in this area here, the upper pole of the breast, then the implant can provide that. So you can combine the implant with a lift to not only lift up the nipple position, but also to give you some more upper pole fullness and just more fullness to the breast in general. All right, that's the upside. Now, what's the downside? Well, if you have a large breast, and really what you want to do is kind of reduce the breast because it's heavy, because you're having back pain and you're having neck strain, you're having symptoms from the weight of the breast. If you're adding an implant, then you cannot reduce the breast as much as you could if you didn't add an implant. Okay, why? Because logically an implant has a certain degree of volume, a certain mass. Okay, so if you're removing a whole bunch of breast tissue, but then you're adding this, then you're adding back volume, you're adding back mass. So the overall, amount of weight that you're reducing is less. So think about it in terms of grams, which is how we measure things. So say you have a very large breast, we do the kind of breast lift, breast reduction, and we remove, say, 800 grams of breast tissue. But then we add a 400 cc implant. Okay, a cc is 1 gram, so we're essentially adding back 400 grams. So then the net loss would only be 400 grams, as opposed to where we're just doing the breast reduction on its own, you would be losing 800 grams. Okay, does that make sense? All right, good. So the advantage to the implant, more upper fullness. The disadvantage to the implant, less amount of a breast reduction basically than you could do otherwise. All right. Okay. So you came in, we did your measurements, we noted the amount of ptosis, we took in your desires, and we came up with a plan. Say, for example, okay, for this particular patient, we're going to do a lollipop breast lift with a moderate size implant. Okay. All right. So then we go into the OR. And everything does great, and then post-op, okay, you will, we do all these cases under general anesthesia, okay, so you do have to be here with us during the PACU recovery time. You're here usually about an hour or so, but then you are able to go home, so it is an outpatient procedure, and you go home the same day or to wherever you're staying, whether it's a recovery house or anywhere else, okay? All right, so what is kind of the long-term care for that? So you are going to leave here with a surgical bra on. You're going to wear that surgical bra for about a week. After that, you can switch to any soft cloth bra as long as there's no underwires. All right. Range of motion, each surgeon is particular about this. For me, I'm okay with you moving your arms slowly in any direction. Okay, there are no limits to range of motion with me from the very first day. But what you can't do is lift anything heavy, do any jerky motions, do anything strenuous. All right, so you can't do any of that because it's going to be 6 weeks of no heavy lifting, no strenuous activity, and no swimming or submerging the breast underwater. So you can only shower for the first 6 weeks. Okay, the first shower is 48 hours after surgery, and then after that, only shower for 6 weeks, and then you should be okay to go back into the pool or the ocean or anything else after that. Okay. Now, in terms of sleeping, most patients are more comfortable sleeping with a couple of pillows behind the back, with their back a little bit upright, especially that first week, and then after that you can probably start to kind of lay more flat. Okay. All right. So that's our kind of our post-op instructions there. Of course, everyone gets their prescriptions, which are going to include an antibiotic, pain medication, and anti-nausea medication as well. All right.
Are there chances for you to get ptosis again after a lift?
Yeah.
Will an implant prevent that, or
It won't necessarily prevent that. So are there chances? Yes, there are chances. Will an implant totally prevent that? No. Can the implant make it so that you have more upper fullness for a longer period of time? I would say yes. Okay. But here's the thing: skin is stretchy by definition. Okay, and anything that is stretchy and has something in it, and there's gravity, pulling on it for years and years and years, can definitely stretch out again. All right, and then what if certainly if something else happens, such as pregnancy or massive fluctuations in weight, that can certainly cause a recurrence of the ptosis as well.
So if a person got a breast reduction that's a few years old, and then now looks at their breast and thinks that they need a lift, is that possible?
It is possible. It is much more tricky the second time around. Okay, so what does a surgeon need in order to go in the second time around? It's very, very helpful to have your operative note from your first procedure. Okay, because the way that typically a breast reduction is done is that you're placing the nipple and the areola on what we call a pedicle, basically on a bridge of tissue that allows it to survive, okay? And you have to know in what direction that bridge came from, because there's different sorts of pedicles. There's what's called a superior medial pedicle, where the blood supply is coming from up here. There's an inferior pedicle, where the blood supply is coming from down here, okay? And if you don't know that, and you go into your second operation, and you cut off that pedicle, then that nipple could die, okay? And that's bad. Nobody wants nipple death. Okay, so whenever you go for a second breast reduction or a lift after a breast reduction or a second lift, it would be very, very helpful for your surgeon for you to have the operative note from your first surgery so they can plan accordingly and not put that blood supply to the nipple area in danger.
How long after breastfeeding can I get a breast lift?
So, you want to wait at least 6 months, okay? So you want to stop breastfeeding, wait for about 6 months, and then it's okay for you to get really any breast procedure, whether it's a breast lift or even a simple breast aug. Reason for that is because before then, the milk ducts will remain open. You're still kind of, even though you don't outwardly feel like producing milk, the ducts are still kind of working, and when we cut through there, we actually see milk coming out. And why is that a bad thing? Because there's more bacteria in there. That means that the ducts have been open. That means that bacteria could potentially go the other way, like in through the nipple, down to the duct. And so whenever we see milk, we basically we're afraid then that we're going to get an infection, because the chances of having bacteria in those milk ducts is higher. So that's why it's very important to try to wait at least 6 months and have all those ducts closed up before you do your breast surgery.
Can you combine any procedures with a breast lift, like getting arm lipo?
If you're doing just arm lipo, yes. Okay, again, we have those limits with the 1 liter, so the arms usually have less than that. So yeah, we can certainly combine a breast lift with an arm lipo. Of course, what's the most common thing we combine it with is a tummy tuck. That's your classic mommy makeover, right? So mommy makeover, the most classic one is your tummy tuck with your breast lift and implant. And so that's a very, very common combination there.
What are the odds of a patient that can lose nipple sensation after a breast lift?
Great. All right. Good question, because now we're going to get into the possible complications.
Perfect.
Okay. All right. So Losing sensation. Losing sensation happens fairly often with a anchor type breast lift, okay? All right, not as much with the donut or the vertical, but certainly with the anchor type you can have changes in nipple sensation. Typically it's a loss of sensation. Typically it's not 100%, so you have some sensation, it's just not the same as it was pre-op, okay? I would say most patients have some sort of change in their sensation. To what degree varies greatly between patients. You have patients that have no loss in sensation, have patients that have lost almost completely all their sensation, but the most common is somewhere in between, okay? All right, so what are the other potential complications? So of course, bleeding is always a complication, so we try to be very careful with that. Could you potentially develop a hematoma after surgery? Yeah, it's possible, especially if you're doing a lot of that strenuous stuff with the upper body or jerky movements or things like that. So you don't want to do any of that to try to minimize any potential risk of bleeding and hematoma. If you do have a hematoma, a lot of times you have to bring you back to the OR to evacuate that hematoma and wash everything out and close things up again, okay? And stop the bleeding, of course. All right, infection. We always worry about infection, especially if there's an implant, okay? Why? Because if the infection reaches the implant, then a lot of times we have to remove that implant, wait for the infection to clear, and then come back in 2 or 3 months and try again, okay? So we give you antibiotics before and during the surgery, and after surgery in order to minimize the risk of infection there. Okay, of course you want to be very careful. You want to take care of your wounds. You want to make sure nothing gets into those wounds. You want to wash starting at 48 hours in the shower with antibacterial soap. You just want to take great care of all your incisions so that they don't get infected, and you especially don't want your implant to get infected if you have one. Okay. Scarring. Okay, so we've talked about the scar patterns. Okay, so those are different patterns. There are patients that are susceptible to hypertrophic or keloid scars. Okay, so especially when you're doing an anchor type incision, the scar burden is fairly high. So there is a potential for hypertrophic or keloid scars. So we got to really take care of the scar post surgery. All right, we start with these skin tapes that are on there for about 2 weeks. Once those come off, we start using silicone-based scar creams such as Silogen, which is the one that we recommend here. If you start seeing any evidence of a keloid scar, then sometimes we have to inject them with steroids such as Kenalog, okay? So those are the things that we got to watch out for the scar. But massaging the scars twice a day, religiously, okay, starting at 2 weeks for up to a year, could really improve the final look of the scar. It takes a full 12 months for a scar to mature, so you have that amount of time to work with it. Okay?
What's the maximum weight that you'll accept for a patient who wants a breast lift?
The maximum BMI would be 33.5, so that would be the maximum BMI. All right, wounds. So there's one area in here, we call that the upside down T, because it kind of looks that way, like an upside down T, or the triple point. Okay, that area there can sometimes open up. Okay, that's not that uncommon. It can open up about 1 centimeter or so. We just treat it with some antibiotic ointments and dressing changes, and that tends to heal on its own. So it's not a huge deal, but if you've never seen it before, you may get surprised or you may get worried. And we just teach you how to take care of it. Okay, that's the most common thing, and like I said, usually it just heals on its own and you're good to go. Could problems with bigger wounds happen? It's always a possibility, especially if there's an infection. Sometimes there's an infection and the wounds tend to open up, and then we have to treat those wounds for a longer term. We could do dressing changes. Sometimes if it's very severe, we may have to do something called a wound vac. That's a possibility as well. Okay? All right. And then if you have an implant, you have all the potential complications that are associated with implants. Okay, so if it gets infected, you could lose the implant. You could potentially get capsular contracture in the future. You could potentially have an implant rupture as well. So I know we discussed all these implant complications the last time I talked about breast dog. So basically all these things that can potentially happen with an implant, of course, can happen with a breast lift with an implant. All right? And then the most feared complication, which I didn't write here until now because I want you guys, the most feared complication is nipple areolar complex, okay, which is the nipple and the areola loss or death or necrosis, okay? That's the most feared complication of, especially this pattern here, the anchor type breast lift or breast reduction, all right? How can this happen? Well, you're removing a lot of tissue, you're removing a lot of skin. By definition, you're removing a lot of blood supply to the nipple area, okay? And then you are creating that pedicle that we just talked about a few minutes ago, which is the skin bridge that's supposed to keep the blood supply. But sometimes, unfortunately, that blood supply in that skin bridge is not enough. And when that happens, the nipple turns like black, and dies. And that's not good. All right, what is the risk of that? Depends on what surgeon you go to. In my hands, is extremely low, less than 1%. But if you go to someone who's not experienced, this could potentially happen. Okay, and experience is not just about the technique. It's also about how far in the experience that you had, how far you can push it. Okay, meaning you can only put in an implant so big when you're trying to do all these maneuvers. Okay, when you're trying to do an anchor type breast lift in someone who has a very long breast and putting in an implant, you can't be too aggressive with it. You can't be putting an 800cc implant and trying to do all these maneuvers at the same time, because you know that the risk of nipple death is going to be very, very high. So that's where the surgeon has to educate the patient and tell them, I know you want this super, full look, this top-up look, but it's just too risky to do it all at once. And so if you really want that look, let's do what we can now, and then perhaps you can come back later and exchange your implant for a much larger implant at that time. But if you try to do it all at the same time, your risk of nipple loss goes way up, and it's just not worth it. Okay?
If you have patients who are showing signs of nipple necrosis post-op,
Yeah.
what do you do to reverse it? Or can you do anything to reverse it?
So that's another thing. So you want to go to a surgeon that is like on top of these things, because you have to react quickly, okay? If you see signs of nipple loss and you waited a week, that's it. It's done. Your nipple is gone forever, okay? But if you catch it the next day, or even if you catch it in the operating room, then you have a chance to do something about it. Usually the first step is actually you have to release the sutures. You have to release the incision, allow things to open up, and so more blood flow can go through. Then the next thing that you do is that you use a special ointment. It's called nitrobate. It's similar to the ones that people with angina, with the heart, that they use to vasodilate. You use that same cream, nitrobate. You put that on the nipple area. Sometimes you give them an oral medication as well. And you hope that with the combination of all of these maneuvers, so releasing the sutures, using the nitrobate, using that oral medication, it's called ptosis, and plus minus, if you have the ability to do so, hyperbaric oxygen, if you combine all those things, you could potentially save a nipple that is struggling. But you have to do it early. You have to do it within 24, maybe 48 hours max. After that, there's really no going back.
When is a mesh insert necessary for a lift and reduction? Can the mesh cause infections or complications?
Okay, so that's a whole other level of complexity that I wasn't really going to get into, but it is a good question. So first of all, for those that haven't heard of this, why use a mesh, right? So what happens sometimes, because skin is stretchy, sometimes it's too thinned out, it stretches too much on the bottom, and it doesn't have enough support to hold an implant. And so one of the solutions that we can do to help that problem is to go in and put what we call a internal bra or a mesh. It's typically some sort of biological mesh, okay? At least I like to use a biological mesh, which, what does that mean? It means that eventually your body, kind of grows into your body grows into the mesh, and it becomes kind of eventually seamless with your body, okay? It's not made out of a synthetic material, okay? So you want to use that biological mesh that's going to create that support for the implant so that you don't keep having the problem of bottoming out, okay? Now, does the mesh increase potential risk for infections? It does, because you're adding another foreign body in there. So you're not only adding the implant, but you're adding the mesh, okay? So you have to be really, really careful with infection. So you want to, you wash out the pockets with antibiotic solutions. You give the patient all the antibiotics they're going to need to try to minimize that risk of infection until that mesh gets incorporated. The thing is that it takes your body approximately 2 to 3 weeks to really incorporate into that mesh, okay? So, before then, that's where kind of when the risk is higher. Once that mesh is incorporated, the risk for infection is lower, but of course it's never zero, okay? All right, so we talked about NAC loss. That's the most feared complication of any aggressive lift, and that's why you don't want a surgeon who's going to be too aggressive and put that nipple in danger. And you want a surgeon that's going to be vigilant and make sure, and if they spot a problem, whether it's in the OR or right after the OR, they can fix the problem quickly. Okay? All right, I put this under other, because it's not really, I wouldn't call it a complication, but there are potential issues with breastfeeding, okay? So, especially for this anchored pattern type breast lift or breast reduction, not all women are going to be able to breastfeed afterwards, okay? So about a third of women are able to breastfeed, about a third of women are able to breastfeed, but still need some supplementation with formula. And then the last third of women are not able to breastfeed at all. Okay, so a third can breastfeed no problem, a third can breastfeed some, but need supplementation, and a third are not able to breastfeed at all. And so if you're someone who's thinking about having kids after the procedure, that's something that you have to accept before undergoing this procedure. Okay? All right. So I think we've done a pretty comprehensive review there. Okay, so now it's time for my new segment, which I hope you guys are catching on to, which is called The Real Deal with Dr. Alex Earle. Okay, so what is the real deal with Dr. Alex Earle regarding breast lift? Because we see this a lot, and unfortunately with breast lift, we see a lot of patients with unrealistic expectations. Okay, because they come into you, they have a ptotic breast, can even be like a grade 3 ptosis. And then they show you a wish pic, and the wish pic is if someone's had a breast augmentation. Someone that started with, say, like an A cup or B cup, no ptosis breast, and got an augmentation, and they're showing you that as their wish pic. And I'm going to tell you right now, a breast lift with implants will never, let me say it again, never look like a breast aug. It's like someone started with a small breast and has just a breast aug, and it's mostly implant, okay? They will not look the same, okay? Because skin is stretchy. Skin is stretchy and it tends to stretch over time, okay? Not only that, but the skin of a breast that's a grade 3 ptosis or even a grade 2 ptosis is poorer quality than the skin of someone who's never had ptosis, who's had just a small breast with no ptosis, okay? Why? Because that breast grew at some point, right? That's why it's ptotic. So maybe the patient went through pregnancy, or the patient went through great changes in weight, or just the fact that there's hormones in their breast tissue and their breast just grew, okay? But that skin has been stretched out once before, and therefore that makes that skin of poorer quality, okay, than one that has never been stretched out before, okay? That just makes logical sense. And so I can do a breast lift in the operating room, put in your implant, do your breast lift, and make things as tight as possible within reason, so I don't run into problems, right? I don't want to run into issues with nipple death and open wounds and all that stuff. But I make it as tight as possible within reason, and it's going to look very nice and tight and high on the operating room table, okay? The problem, or the issue is that all you must be aware of is that over the course of the first 3 months, you're going to go through a settling process. And that implant that starts off high is going to settle down, and as the implant settles down, it starts putting a bit more weight, a bit more pressure on that bottom half of the breast, okay? And that skin is going to give to a certain degree. Can I predict exactly how much it's going to give? No, I cannot, okay? There's some that I can say, well, I think she's going to do pretty well. There's some I can say, well, she's going to have much more of that stretch, perhaps potentially even bottom out, okay, because of how thin or what the quality of that skin is. But can I predict exactly where things are going to end up? I cannot do that, okay? All right, so it is not a breast augmentation. The expectation cannot be that the same for a breast lift with implants, especially for a grade 3 or a grade 2 ptosis with an anchor pattern. The expectation cannot be the same as a breast augmentation, okay? Everyone should really understand that. It does take 3 months for them to settle, okay? Sometimes when you do a breast lift with implant, the implant looks high, the nipple position still looks a bit low, things look a bit kind of tight on the bottom of the breast, and things may just look a little bit off initially post-op, but that's okay, because it's going to take 3 months for the implant to settle down, for the bottom part to round out, for that nipple position to come to the front of the breast, and for that scar along the bottom to kind of stretch out a bit. All right, and that's what we expect. But it won't be sooner than that. You're not going to be like the super fast person, okay? It takes everyone 3 months to settle. All right, we talked about the skin being stretched, and that's a problem. All right, perfect symmetry. There is no perfection in life. We're not perfectly symmetrical even before doing anything, and you probably will not be perfectly symmetrical afterwards, especially if you're starting with breasts that are very asymmetrical, okay? If you have like a B cup on one side and a D cup on another, we can make things a lot better. We can make